T1 is tumor less than 5 centimeters, no nodes. T2 is more than 5 centimeter, no extracellular invasion, that is stage 2. And the stage 3 and stage 4 have been well represented here. So before deciding your adjuvant treatment, you also need to know the S-GRAS score or the GRAS score. Initially, it used to be the GRAS score. Now it's the S-GRAS score, where your stage, grade, resection, age, and symptoms, all of them have an important implication on the adjuvant treatment, on the prognostication. So based on all these factors that I have talked about, there are 3 risk stratification groups. The low risk group, that is NSAT stage 1 or 2, and in the low risk group, the Ki-67 is less than 10%. Then there is standard risk group, which is stage 1, 2, and Ki-67 is between 11 and 30%, or stage 3, where the Ki-67 is less than 30%. And the next group is very high risk group, which has any of the following. That's Ki-67 more than 30%, large tumor thrombus in the vena cava, stage 4, or R1 resection. So let us quickly run through the evidences that are available. Anyway, the level and the availability of evidence in adrenocortical carcinoma is very sparse, but whatever we have, we will quickly run through them. Talking about low risk, we have the ADIOVO trial, which was a phase 3 randomized control trial that shows that low risk ACC patients may be safely observed post-op mitotin, and no clear benefits in the low risk group. But the limitation of this study was there were very few stage 3 patients included, and ACC stage 3 is supposed to be, which we have just discussed, a known strong adverse prognostic factor. So the ongoing trials are ADIOVO True, where the arms are assessing adjuvant mitotin alone, or the adjuvant mitotin with platinum-based therapy and etoposide. Similarly, there's a phase 2 randomized trial going on, where the arms are SOC or mitotin versus EP and M. And the primary endpoint is disease-free survival. In the next few years, we will have answers to these questions. Talking about mitotin, it's a parent compound of an insecticide, and it is not easy to administer or to acquire. A lot of countries have restriction, limited manufacturers, restricted distributors, narrow therapeutic window, toxicities including severe neurotoxicity or endocrine disturbance, and very delayed onset of action. So that's where you try to realize that in all these high-risk features, patient, is there anything else that we can do? So this was one of the early trials, which it is a retrospective trial from MD Anderson group, which showed no significant benefit with adjuvant radiotherapy. It was a radiation trial. Here we are trying to assess the role of radiation. So the total number of patients were 48. Radiation group was 16 patients, no significant benefit. The next was the University of Michigan study, which was conducted between 91 and 2001. See the number of patients in ACC, very small. So 20 patients with R0 or R1 resection, and this study showed a significant local control benefit with radiation. The median dose was 55 gray. Then Nelson study, that was a total number of patients were very large, that were analyzed were almost 1,100 patients, and adjuvant RT, this is one of the largest studies at analyzing ACC and the role of radiotherapy. And in this study, there was overall survival benefit in R1 subgroup, and that 10 to overall survival benefit in all comers. Similarly, this is a retrospective Garzai study, propensity match benefit in OS as well as recurrence-free survival. This is again Wu study. This showed a significant benefit in early stages also, that is stage 1 and stage 2. So with all this data, some prospective, some retrospective, some propensity match, and this is all that is available. In ACC, we do not have large randomized prospective trials, well-designed randomized controlled trial. So this is all that we have, and from this we need to make an inference, and we are seeing that even in early stages, some studies are showing significant benefit in overall survival. This is the meta-analysis, and what does the meta-analysis show? Adjuvant radiotherapy significantly improves OS, especially in high-risk group patients. That is R1, high Ki-67, or advanced D-stage patients. Adjuvant mitotain provides both OS and RFS benefits, especially in margin-negative patients, and combination therapy, that is combining mitotain and radiotherapy, may offer local control, particularly in high-risk patients and R1 patients. Yesterday, Dr. Vedang's group and Vasant Priya, they presented this study. This is not yet published. So I could see, I thank Dr. Vedang for the slides. So even in his study, adjuvant RT as compared to surgery alone has a significantly improved loco-regional free survival. And in this study, we have also seen that few factors like functional tumors, which have a improved outcome with radiotherapy in terms of DFS and OS, or if you have high mitotic index, that has an improved DFS if you deliver adjuvant RT to these patients. So all that I talked about, I have summarized in this table from whatever data we have today. So most of these studies have shown that radiation has improved local control. Some studies have shown that radiation has improved overall survival, and some studies have shown that radiation has improved survival even in early stages. So this is the FASTNAT's guideline, which has come out in 2021. So they talk about giving mitotain in early stages, and they talk about delivering radiation in microscopically or macroscopically completely resected patient, that is R1 and R2. I will extend it. NCCN currently talks about giving radiation to high-risk local recurrence feature, including positive margin, Ki-67 more than 10%, rupture of capsule, large size, and high grade. And this is my last and concluding slide, where after doing all these studies and this presentation, my recommendation would be, from all the various retrospective and prospective series, all that NCCN has said and FASTNAT study has said, plus important additional risk factors like functional tumors, venous invasion, high MWS more than 5 or equal, and tumor thrombus. All of them will benefit from adjuvant radiation. We cannot write off mitotain based on just ADIOVO 1 data, and mitotain is also here to stay. But as I said, mitotain is not as easy to administer. So these are the areas where we can take support of radiation. Thank you.
Thank you, Dr. Costa. That was a wonderful presentation on a difficult topic, and there are so many dilemmas there in such a less commonly seen disease. Thank you very much. So next we have Dr. Ashish Khanna. He will be speaking on metastatic hormone-sensitive prostate cancer, the treatment paradigm shift, exploring the doublet and triplet strategies.
Good afternoon, everybody. Actually, this talk was to be given by Dr. Mahindra Pal, and unfortunately, because of it, hello. Good afternoon, everybody. This talk was to be delivered by Dr. Mahindra Pal. Unfortunately, because of some circumstances, he's not been able to be here today. So I'll be taking this. So prostate cancer, we know, is a spectrum disorder. So it can be vary from a hormone sensitive phase to castration resistant phase. And the past decade has seen a bloom in the treatment strategies to manage the entire spectrum of the disease. And we have seen quite a lot of success with addition of various agents to the existing surgical castration or the medical castration agents. We have seen that various trials have demonstrated the efficacy of addition of either the androgen receptor pathway inhibitors or docetaxel or radiation therapy for that matter. And triplets also have come into the picture. As we are talking about treatment de-intensification and toxicity management, it is important to analyze the data given in that format. Um, there were multiple slides that had modified, but I think the wrong presentation has been uploaded. Multiple agents such as docetaxel, abiraterone, enzalutamide, apalutamide, and now the triplet agents have been used in this domain of metastatic hormone-sensitive prostate cancer. And we have been able to provide some benefit to our patients over the existing androgen deprivation. Out of these trials, we have now been able to better risk stratify our patients by prognosticating them into high risk category as per the latitude trial or high volume category as per the charted trial. And it is seen that metachronous metastasis, whereas vis-a-vis de novo metastasis are different in their biology. And we can see that metachronous low volume do much better as compared to those with metachronous high volume, followed by de novo low volume and de novo high volume diseases. Coming on to a brief description of the studies, we know that the agents that have been tested are docetaxel, abiraterone, darolutamide, apalutamide, and enzalutamide. All of these can be used as doublet agents with androgen deprivation, with all of them providing overall survival benefit over the standard androgen deprivation therapy. A special note about darolutamide, the ARANOTE study, it showed almost 46% reduction in the mortality as compared to androgen deprivation alone. So we know that the treatment landscape is evolving. And just to highlight again, all of these agents have provided overall survival benefit. Coming on to the triplet therapy was the main domain of addition of docetaxel and an androgen receptor pathway inhibitor was that there are some components or some cells which are not responsive entirely to this androgen receptor pathway, and it is imperative to treat them because these may be the cause of progression to castrate resistant phase. The two trials that are important, require important mention here is the PEACE-1 trial and the ARASENS trial. The PEACE-1 was actually not for the triplet therapy per se, but because at that time the ADT plus docetaxel became the standard of care, abiraterone was being given to these patients, and a subset of these patients were analyzed for the efficacy of the triplet therapy. ARASENS, on the other hand, was a prospective trial that was primarily aimed to demonstrate the benefit of triplet therapy in these patients. So for ARASENS, I would like to highlight it is the trial was to randomize patients of metastatic hormone-sensitive prostate cancer to with ADT, docetaxel 6 cycles with darolutamide, vis-a-vis docetaxel 6 cycles with ADT and a placebo agent. The important thing here is that docetaxel was administered within 6 weeks of start of the study drug, and the primary endpoint was overall survival. So we can see that the triplet therapy with the addition of darolutamide to docetaxel significantly improved the overall survival over the existing standard of care, which was ADT plus docetaxel, with a 32% reduction in the risk of death. If we substratify and analyze the effect, we can see that the addition of darolutamide to docetaxel was beneficial for patients with high volume, high risk, as well as low risk disease, but did not provide overall survival benefit for low volume disease. And the time to castrate resistant prostate cancer was the effect was beneficial for irrespective of the category in every domain of these patients. PEACE-1 also with abiraterone and docetaxel has proven that the triplet is better than the doublet. However, if we see the toxicity profile, which is the main topic of our conference here, the ARASENS outperforms the PEACE-1 trial in terms of the toxicity profile. And we can see that the treatment discontinuation rates between the placebo and the darolutamide groups were absolutely comparable. And the proportion of patients who were able to take darolutamide for more than 2 years was significantly more than the placebo arm. Whereas in the PEACE-1 trial, we can see that the treatment discontinuation rates with the abiraterone arm was significantly higher than the placebo arm, and the treatment discontinuation was more with abiraterone. Darolutamide did not affect the ability to complete 6 cycles of docetaxel, which is very important to highlight that there is no additive toxicity with darolutamide. Vis-a-vis for abiraterone, we know that there was discontinuation. Abiraterone has side effects such as derangement in the blood pressure levels, hypertension, there is hyperkalemia, and there can be side effects because of isolon, that is derangement in blood sugars. So darolutamide is also the important thing here is that most of our patients are elderly with multiple comorbidities and are on polypharmacy. They are either being treated for their hypertension, their obesities, their cholesterol levels, maybe having CAD. So it is important as a clinician that when you are prescribing any agent to these patients, it is important for you to treat the patient and not the disease per se. You have to see what other agents they are taking and what important interactions the agent may have. And in that matter, darolutamide, as can be clearly seen, has least amount of drug-drug interactions as compared to abiraterone, or for that matter with enzalutamide or apalutamide. So the key takeaway with triplets is that darolutamide trial, the RSN trial, was the only prospective trial. It has shown its effect with more than 30% reduction in risk of death, and the discontinuation rates were similar to the placebo arm. That is, it is a very well tolerated drug. On the other hand, Peace One trial obviously is not a planned analysis for the triplet, but it has shown a 25% reduction in the risk of death. But at the same time, abiraterone along with docetaxel can have additive toxicity with discontinuation and may require a more intensive monitoring for these side effects. Finally, concluding with the take-home messages is that as clinicians, it is important to tailor our treatment for the disease as well as considering the patient in a holistic manner, taking into consideration his financial status, his the comorbidity status, performance status, and the disease status. Obviously, in today's world, the doublet is the minimum that you should offer your patients. There is a very limited role of a monotherapy. Um, if the clinician judges according to the entirety that the patient is a good candidate for triplet, it should definitely be offered. It is important to proactively manage the adverse effects so that the patient is able to tolerate the brunt of disease and along with the treatment. It is important, in addition to treatment of the disease, it is important for us as clinicians to make efforts to improve or maintain the quality of life of our patients. Thank you very much for your time.
Thank you, Dr. Ashish, for sticking to the time. And we'll take questions at the end. May I invite the next speaker, who is my friend, my colleague, Dr. Sabrada, talking on evolving landscape in the hormonal management of prostate cancer.
Chairperson dignitaries. So in the following slides, we'll just reiterate the fact that the LHRH agonist is not anyway inferior than the antagonist, and somehow it is superior also. And it has also good cardiovascular safety profile. So just you all know this, how the agonist and antagonist acts. So that our study molecule is the Joladex, that is the goserelin. So it is now available in 1 monthly depot form, that is a 3.6 milligram, and 10.8 milligram depot form, that is for 3 monthly. So it is available in a pre-filled syringe, that is the safe system syringe. Why it is safe? Because it has a needle cap, it has a stopper at the plunger. So when you have to administer, you have to just uncap the needle cap, and you have to remove the stopper, and then you have to inject. And in the single injection, the gel form deposited in the subcutaneous space, and the plunger gets withdrawn. So there is no needle prick injury. And it is not a liquid form, so no need to displace the air bubbles. On the other hand, Degarelix, when it is given in the first setting, it is in 240 milligram dose. So it is a huge quantity you have to reconstitute, so more administration time, and there is a possible some injection site pain or rashes in some patients. So coming to the cardiovascular safety data, which is the most debatable topic, why we are concerned? Because the most of the prostate cancers occurs in the elderly group, which has defined cardiovascular comorbidities like hypertriglyceridemia, insulin resistance, and hypertension. So there is no like randomized control study, few limited studies, and those all are for 1 years of administration of the GNH agonist and antagonist. So it is the first pronounced study that evaluated the major adverse cardiovascular events. So this was in all patients, it was 1:1 randomization, though the intended population was 900, but it only occurred 545 patients, and patients was randomized 1:1, and the study outcome was that the no significant difference in the major adverse cardiovascular events was recorded between the two. So there are some real world evidence also. This is a database comprising of 5 countries, UK, Scotland, Belgium, Netherlands, and France, and they compared the 6 major cardiovascular toxicities. There is a cardiovascular disease, ischemic heart disease, acute myocardial infarction, arrhythmia, heart failure, and stroke. And you can see that the around 48,000 patients received GnRH agonist, and antagonist received only around 2,000 patients. And in this study, they have, in this database, they have found actually no difference in the cardiovascular safety profile between these two molecules. So another concern was, suppose you start with the antagonist and subsequently you shift to the agonist, whether there is any like safety breach or any like overall survival or cancer-specific survival dependence. So it is a retrospective study in which there was 108 patients. In few patients, subsequently antagonist was changed to agonist, and in few patients it remains the same. So you can see the overall survival was better actually in those group of patients which has been shifted from antagonist to agonist, and also the 5 years over cancer-specific survival was also better in those patients. This is the curve showing the these two things, overall survival and cancer-specific survival, and this is the this Kaplan-Meier curve shows the time to castrate resistance. So you can see the blue curve is the changeover group, which is showing the later median time of having the castrate resistance than the only the Degorelix group. So now the another molecule is the oral antagonist. There is a Relugolix, but the hero trial which was performed with the Relugolix had some limitation because it was centered only on the two things, that is the achieving the castrate range early and the time period for the 1 year the castrate range is maintained. So there are several criticisms, like it was not patient centric, that the end point was like not progression free survival or castrate free survival. So there, so in NCCN also take the oral antagonist has not been adequately studied in combination with other like androgen receptor pathway inhibitors or like docetaxel or abiraterone, and data are limited on the long-term compliance of this molecule. So these are just a summary of the hero trial. So the goserelin molecule has been used in localized prostate cancer, locally advanced prostate cancer, metastatic prostate cancer also. And in these, all the huge volume studies, these are so good efficacy. So just to summarize and go through, so long-term and overall survival, goserelin has been effectively used for more than 3 decades alone in combination with other therapies, and it has a good safety profile and tolerability profile, and patient also prefer it because of the 3 monthly doses. And some concerns about the cardiovascular toxicity, but as you have seen with the studies, it has not shown to have increased cardiovascular toxicities. Thank you.
Thank you. With that, we end this session. And next is the panel discussion. So,
Hello. Thank you. First of all, I'm Dr. Harshit Gar. I'm a uro-oncologist, so I'm a urologist and being given a very interesting topic to talk on systemic therapy in metastatic RCC. ठीक है. So, since I am there between the food and the conference, so we'll wrap up real quick. And that is the modus, and the topic is very, very interesting. We have Dr. Arpit Jain, medical oncologist, Dr. Dharmishta, medical oncologist from Dr. Rajiv Saini, Dr. Gautam Ram Chaudhary, Dr. Mangesh Patel, radiation oncologist, Dr. Kanesh is not able to join, so we'll have Professor Amlesh Seth with us on the dais. Dr. And we have our international speakers, Dr. Badri, Dr. Ashok Himal sir is not there, Dr. Lin and Dr. Kibble. So we will keep it very quick, very crisp. This is a very interesting topic. So can we have my presentation, please? So we had a wonderful talk with Dr. Gagan and everyone on toxicity. So I must congratulate the organizing team. So has such a unique topic on toxicity reduction. So you see the stones, pebbles. So it's all about a balance. So the disclosure trained from United States as SEO fellow with Rob Swatek. So I'm a surgeon. We have this elite panelist with us. And so, I'll just be very quick. We have mics there. de-escalating systemic therapy in metastatic RCC. Very frankly, in panelists, how many of you have ever heard of this term? Very frankly, I didn't know that in RCC metastatic, you can actually stop the therapy. So, Dr. Gautam, I'll take first from you. Have you ever heard of this thing before, sitting there? In RCC metastatic, I can stop the therapy.
No, not hard, but when we were using the sunitinib,
Yeah.
if you remember, it comes in a two strength,
Yeah.
50 and it's 37.5.
Yeah.
So if toxicity is there, then we reduce the dose. That was my knowledge so far.
Yeah.
You presenting here.
Dr. Seth, I will be very quick here because I have to wind this in 15 minutes. Lunch is waiting outside.
Yeah, similarly, sunitinib, when it was started, and 2 weeks on, 1 week off, the whole idea was the reduction in the toxicity. And whenever there is toxicity, we definitely delay the next dose. And
Yeah.
that's something which has been going on regularly.
Dr. Keeble, quick comments from you.
Yeah, so I'm very fortunate to work with Tony Schwery. So I spend very little time thinking about systemic prostate kidney cancer. I just send it to him.
Yeah.
But he clearly gives patients drug holidays and de-escalates very frequently.
Yeah. Dr. Lin,
Yeah.
I know these difficult questions are urologists, but
Yeah.
we'll take it from you. Yeah.
No, we still see quite a bit of this. I would say that I'm old enough, and many of us are here, to remember before the targeted therapies, we never saw our patients back again.
Yeah.
But now we see patients come back 2-3 years later with metastasis all gone almost, just the primary in place, and we're asked to do the consolidation surgery after a long holiday, sometimes 1, 2, 3 years of holiday, no progression, and we're doing now surgeries on. We didn't used to ever see that before.
Yeah.
But now we're asked more and more to do that during these drug holidays. Yeah.
Dr. Badri, quick comments.
Yeah, I agree with everything that's been said. I actually have 2 or 3 patients right now who are exactly in that situation. And for toxicity and other reasons, they stopped treatment and nothing's happened. And at least one old lady, she actually died of something else while she was watching, her.
So I have a similar
about
case
it.
that I'll show you guys. So I'll come to radiation and then I'll go to the medical guy who never want to stop therapy. So I'll first go to radiation and call Dr. Mangesh. So what do you feel about stopping the therapy?
So I was confused about my role in this panel.
Yeah. No, SBRT is there. You have
Yeah.
to be there. SBRT is there.
No. In a
There should
sense,
be a thought process. You just give SBRT to kidney, so metastasis site, and then can stop your.
so then that
No,
becomes an
it's-
escalation, not de-escalation.
No, you can de-escalate a systemic therapy.
Yeah.
Systemic therapy de-escalation. So
Yeah.
Dr. Dharmishta and Dr. Arpit, very dynamic people with us in medical oncology. Do you want to stop it, or pharma company doesn't allow you to stop it?
No,
They will be unhappy, For next conference, who will pay the travel?
per se, the terminology in particularly metastatic RCC could be new, but with the excellent advances in the systemic therapies, now we are discussing with the patients regarding the de-escalations in terms of either dose reduction or dose holiday.
How do you stop? So we'll come later on. Dr. Dharmishta, quick comment and we'll take a case and we'll go around that.
So contrary to the concept that it is new, actually there are so many phase 2 trials that have been testing this concepts right since 2017 or so. And there have been trials which have recruited around 1,000 patients and the data has come across. But the concept is not so new. And considering so many situations where we can talk about de-escalation, it is about postponing systemic therapy. It is about reducing the dose of an ongoing systemic therapy, or maybe stopping the systemic therapy to give a drug holiday. De-escalation is such a broad concept in
Yeah.
RCC.
I think it's very new, but it's a broad concept, and we are here to discuss this very quickly. Not spend more time on case. 54-year poor lady. Poor is the word there. Hospital staff, trivial trauma, found to have IVC tumor thrombus in the right atrium. Dr. Seth knows this because he operated on that patient. He had to send that patient across to AIMS. So she had this big tumor, 7-8 centimeter, and underwent. She had a lung nodules, pulmonary mets. We discussed this case in SIU. Burjian was there, Libovich was there, and we'll not go into surgery or no surgery. We had a big debate whether with multiple lung nodules and IVC tumor thrombus, good performance status patient, should you operate or not? So we operated, we'll not go to that debate right now. So she underwent good performance status, all those things. She underwent systemic, radical nephrectomy, did well, tumor thrombectomy, started on systemic therapy. We couldn't give her immunotherapy because of the financial constraints, which we have heard. So she started on sunitinib, and 1 year follow-up has now just completed. Her PET scan, follow-up scans showed, more than 80% reduction in the dose burden. And, we all know these, guidelines. And she comes to me every clinic and says she has some erythema in the hands, and she says she's not bothered with it much, but she says, hey doc, till how long this sunitinib has to continue? Please stop this. I have to buy this therapy. My insurance, or this ESI had insurance is exhausted. So, and then I'm confused when to stop. So, what would you say? Do you think 80% decrease in the tumor burden in the nodules? She's doing good. Anyone? Or those who want to stop, or those who don't want to stop? Just have raised hands, quick hands. Dr. Seth, would you think? So she had multiple nodules, not very calm. One nodule was 3 centimeter in size, which gradually decreased to around 1.5.
So far as the financial toxicity is concerned, there is a scheme. Once they take for 1 year, they get free of cost. We have a few patients have afforded it for 1 year, and then they get it right. And the company also benefits, like they get a data of prolonged survival. Well, for 1 year, they continue to do well. And therefore, for this particular patient, I would.
Anyone in the panel who would stop? Dr. Lin, Dr. Badri? No one wants to stop? No. Is it because of, suppose we keep financial toxicity apart, and do you think that, how long would you give it? Like, should we take it lifetime? Yeah. They would say yes. I hope so. Do you want you guys to stop? Medical oncology
I think 1 year is little early to discuss regarding the discontinuation or not. I would like to further extend the therapy for at least 2 years.
I think all agree 2 years is a.
I have one patient who's on this therapy for like this, that he took it for 2 years, then he stopped recurrence, and then he took it for 1 more year, then he had another recurrence, and then another surgery, and then subsequently he's continuing like multiple metastasis, and he is actually alive with metastasis about 14-15 years.
14 is a big number, sir, in a metastatic.
Definitely the tumor biology is.
Yeah.
Nothing beats tumor biology.
And he works, he continues to go for his work. He has significant side effects. So sometimes instead of taking 1 week off, he takes 2 weeks off, even 3 weeks off.
Yeah.
And despite his, but I have had other patients also.
RCC is a heterogeneous disease, so we cannot.
All cancer heterogeneous. We can prostate. We talk it is called heterogeneous disease.
We cannot make that gallbladder patients could be that heterogeneous, or pancreatic cancer could be that heterogeneous. RCC, we have a patients, they last for 6 months. We have the patient, they last for 6 years.
I think totally agree with that fact. And so this concept is recent. These two papers are in 2025 only. One published in European Urology, one in JAMA. That there are viewpoints like strategies for de-escalation in metastatic RCC. This is from UC Davis. Another is from MD Anderson Houston. And so what do we do? So basically, as we all say, we just do adaptive de-escalation. We follow these patients. It's a very personalized decision. Why are we worried about? Because we worried about progression, disease resistance, heterogeneous biology, but we want to stop it because of all the points we discussed. So any specific concerns with ICI, immune checkpoint inhibitors, when you are thinking of de-escalation? Anything you want to share? What do you see? 2 years is done, suppose, but any other point when you're talking about immune checkpoint inhibitors? Okay, I can stop this, or I can give a dose or reduce the dose. What all do you think? Any point, Dr. Dharmishta?
For the immune checkpoint inhibitors, I think the most important toxicity that patients face is a financial toxicity. It is difficult to continue immune checkpoint inhibitors despite the patient assistance programs when we are giving pembrolizumab. At least upfront preparation for 10 lakh rupees of expense is required, beyond which the company will be giving them free doses. That is one of the important things that we do consider. And in the TKIs, that I do feel it is the quality of life that is hampered in terms of the hand-foot syndrome and the mucositis that often requires treatment halting or maybe dose modifications. These two things come into my notice during the clinical
I think
practice.
totally agreed. Dr. Keeble, I'll take a quick question from you, sir. Immunotherapy, you saw earlier system, TKIs and now immunotherapy, and these patients come to you. As per, quality of life and, adverse effects, which do you think is, was doing much better?
So you're asking me whether TKIs have more side effects versus PD-L1?
Yeah.
Well, I think they're sort of different, and patients tolerate them in different ways. I find that most patients, when they have significant disease, tolerates the immunotherapy quite well. It's the patients that are asymptomatic that are very bothered by it. You need to talk about the real serious side effects like the thyroid issues and the lung issues. But I think most patients are willing to tolerate that if they have metastatic disease. I think it's the problem with the adjuvant trials is the patients feel great and they're like, why am I on this?
Yeah.
That's the problem I see.
I think all of us agree with that fact, or do we have anything? I think immuno is doing much better, and that's why, we are all a fan of Keynote 564. Yeah.
Can I say one other thing? I think we're getting, when I say we, it's not the urologists, the medical oncologists are getting a lot better at mitigating and managing the side effects of the immunotherapy. There's fewer surprises now.
Yeah, absolutely. So there's some data from the Checkmate and GU16 trial that even when the drug was stopped, 40% of those patients remained disease free for quite a long time, around 2 to 3 years follow up. So which is thought of time to think that maybe not all need such a long systemic therapy, and that's why we are sitting here today discussing, and we have a refined trial which is trying to decrease the dose of Nivo apart from financial toxicity. And as we all agree, TKIs have more side effects, and we have seen that treatment breaks can actually restore sensitivity. We have given drug holiday regimes in TKIs, so why not immunotherapy? So that's the process. So of course we talk about strategies for de-escalation, tumor characteristics. So if you think, I know more of a medical oncology question, but I'll take it first from urology and then of course take comments from medical oncology. If I'm going to stop Pembro for this patient, or Pembro Lenva, or something is going on for this patient, especially talking adjuvant setting, although we know for 1 year, but if we're thinking, what would you think? Okay, like, you all guys agreed very unanimously that for this lady, we should not stop, the sunitinib therapy. So what is in your mind which says, okay, this patient might do good or this patient might do bad, so let us stop, so don't, Badri, I'll take it from you. Do you think something in your mind when you're seeing this patient going on systemic therapy, okay, I can stop this, I can give it a trial at least. So what do you see in that? Tumor biology or characteristics?
Yeah, you obviously tumor genetics and histology as well, right? I mean, it's predominantly or entirely clear cell. That may be a different approach as opposed to if you have some of the other histologies, whether it's papillary, chromophobe.
Yeah.
So that obviously makes a difference. And I don't know if you're doing tumor genetics on some of these patients. I mean, that can matter as well.
Dr. Lin, Dr. Keeble, quick comments. Like,
no,
RNA sequence. I know there are papers on
yeah,
clustering and
I mean, the lecture yesterday by Fraser, I think it was, talks about the landscape, whether it's immunogenic,
Yeah.
whether it's vascular, and I think that probably eventually we'll be able to personalize our therapy, one hopes. I know that after TKI, the surgeries are a lot harder than after IO. It's clear to me, at least that's what in my experience, has been that way. And so there, in this patient's case, she's doing well after a year. Keep going, because it shows that she's responding. So we'd keep going.
Dr. Keeble?
I have nothing really to add. I mean, I think there are two issues with her. The first is she didn't have a complete response and she didn't have no response. She's sort of in this sweet spot in between where she had a good response. And so that's the kind of patient that you sort of feel like you want to keep on pushing it. If she had a complete response, then you'd feel much more comfortable maybe stopping it and restarting it. And obviously, if she had a terrible response, you'd be switching her to another drug.
Yes, sir. Dr. Seth, real quick comments.
Yeah, one issue is, in RCC, always patients who have pulmonary metastasis, they have always been
good prognostic.
Yeah, good prognostic. And partially, I suspect that there are some lesions which are overdiagnosed as metastasis, and especially the lung nodules, which may actually not be. And therefore, if they are totally stable and there are no fluctuations, I would tend to think that they are non-metastatic, and we should not keep on pursuing. That is one.
Yes, sir.
Oh.
Yeah. 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 Dr. Talwar, please quick comments on this. What do you feel? When do this patient has come, he has taken 2 years therapy or 1.5 year therapy, and he says, doc, stop this. And what would you see in that tumor characteristics, which would say, okay, we should stop it, or okay, we should not stop it, or give it a trial? After how much duration, and what factors were there, why you stopped in 3 and not in others? Yes, sir, we are talking. Yeah. 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 So I think that's the next portion of talk.
Stick to your question. What we are discussing, de-escalation is totally fitting in this your slide. Personalized care. We go for the genetic testing. We go in-depth molecular testing of the tumor, and then we decide this tumor is going to respond to IO or TKI or combination. If combination, then which drug we can use, we can't stop, or which we can, keep at second that we can stop. So personalized care is the way forward, and we all are striving.
Dr. Mangesh, quick comments, and then we'll go to you, medical college. I know you might not be the right person to, but you can comment.
I mean, I think so. I mean, what I can say, if there is a persistent response, so those are the candidates wherein a trial can be designed that whether we can offer SBRT to the primary tumor and there is a sustained response further.
No, Dharmesh and Dr. Arpit.
So in this particular study that you have quoted, this is a very good example of how we can personalize the treatment in these cases. I think the modality that they used in the study was an RNA sequencing on a certain California-based platform, and they have used certain gene signatures to classify into certain clusters. Though it is difficult to access today, maybe we'll have a further discussion along the line regarding the use of ctDNA.
Yeah, this is the future, I think. Yeah.
But
Yeah, so that was another point. Yeah. What a definition of CR will come. Yeah, but sir said complete CR on imaging. Of course, I'm not sure if sir did ctDNA or not, but that is in coming in the definition of, we don't do normally ctDNA very commonly in practice. Yeah, so I think I made it already, very simple. Multiple nodules, not operable. I took it out from surgeon's perspective because if surgeon is there, he will take it out, everything, whatever is possible in RCC. So Dr. Arpit, I think last comments, and then we'll go next.
I think the discussion regarding the de-escalation should be started from the patient first. So if the patient is really aligned that there should be a discussion to de-escalation, because there are uncertainties. If we, like sir said, we have given the sunitinib for 10 years, still the disease get reoccurred.
Yeah.
So it should be fine-tuned
And
with the
even
constellation.
sometimes for 3 years it doesn't recur. We don't know what is happening.
So it should be fine-tuned with the constellation of the genomic studies along with the imaging findings and the patient track on the particular therapies, and definitely the patient preference.
Thank you. So classically, we all know that RCC is a low sharing tumor. ctDNA, earlier ctDNAs are not able to pick it very well. Now we have more sensitive assays. So Dr. Lin, do you see a scope of ctDNA? I know we have trials, Matt Galsky is doing a trial on bladder cancer, doing neoadjuvant, and then, ctDNA, I know. So we are going to get in a surgical free period right now, yeah.
Yeah, my sense is, well, you put it there, that it's a low shedding tumor, and that we haven't had that much success in ctDNA on this, or cell-free DNA.
Any comments from ctDNA on, in RCC? We're using a lot of bladder and prostate, I know. Yeah, it was a negative. I think they're still trying to develop, but there is a potential in bladder. Do you see potential of ctDNA in kidney?
So there is that study in the adjuvant setting, that is IM Motion 010, and they have found that in the patients who have ctDNA after the surgery, they do worse. And the trend, if they gets negative on treatment, they do finer than the comparator arm.
Yeah, I think you're very rightly said. We are in very exciting times for ctDNA. We have got some trials running on, and we have to wait for their results. What do they say before going on saying definitive conclusion? Imaging, which is most commonly used. We all know RECIST criteria. We have learned it, mugged it. Everyone using it day in day out. But many a times, RECIST, there's a pitfall discussion in because when you have immunotherapy, there could initially increase in size and then decrease. Just like after radiation, you have this PSA bounce phenomena. So I'll take it from, sir, you you said in imaging. In imaging, initially the size has increased and then gradually it goes down, but it's not completely resolved. So do you think you cannot stop, but do you think you could rather decrease the dose of the immunotherapy you are giving to the patient? Have you ever thought of this thing, or do you think that? Yes, sir. Yeah. And what is the best imaging for you to follow these patients right now in your practice? PET. Contrasting. With the contrasting CKD or you do contrast scans, no? What I feel, sir? Contrast CT scans. So are you doing routinely FDG PET in your follow, or are you doing CT, KUB or kidney or CT, chest and abdomen with a contrast in your practice for follow up on these patients? Okay. Dr. Raval, sir, what do you do normally in your practice? FDG PET or CT chest abdomen with IV contrast? Yes. Yeah. CT scan. So quick comments. Best imaging of choice for yours in your practice, metastatic RCC on follow-up. Dr. Badri. CT. CT. Is it a PET CT or is it a normal CT with a CT with contrast, without contrast? With contrast, with contrast, with contrast? PET or CT with contrast? Yeah, lymph nodes are there, suppose, yeah. CT. No PET?
Does not add much.
Anyone using PET? Medical oncologists saying not using PET?
Abdomen preferable, but of course, come with a single kidney kind of situation.
Yeah, then you're going FDG PET, but a stable patient. Okay.
Sometimes.
Yeah. If you don't do it, someone else will do it. Yeah. FDG PET is so easily accessible. If you don't do it, someone else will do it. That's what I have learned from my practice in 2 years, very short practice. I was a very anti-PET guy. I was not using PET. But as soon as my patient lands up to a medical oncologist or someone, that FDG PET eventually comes in picture. And in India, FDG PET. So it's interesting. I have got 10 or 12 people around here, big people in geo oncology. None of them said PET scan, but still PET is the most common imaging to be done. And it still remains the standard of care. And we say that, you do it from the same center and all those things. So, but yeah, interesting. Thank you. And we are, of course, AI and radome is coming up. We don't have a solid data on that, but that is something which is going to change the, this strategies. So today I will quickly close this from take home message. So this is the, picture. So as everyone says, if 2 years, they have just a suggested, it's a review article, suggestion that if you are done with 2 years, so they don't talk about regression, they say stability. So if you're 2 years, the disease is stable and not progressing, then you might consider using some of the, markers or, which we have discussed, and then you can consider stop or tapering the therapy. So the idea is just de-escalation is the need of hour. Challenging is how to identify best patient. It is heterogeneous disease, especially when you're talking of ICI and TKI, that makes things more complicated. Precision and personalized medicine is the key there. And these are very exciting times for, kidney cancer, as for all cancers. And so we just want to end up that more isn't always better. It is not that sometimes more is just more. So, it's time that we have to go towards de-escalation. We don't need to, that's just like, Elon Musk is going on and going on, increasing his progeny. So we don't need to go on and go on with immunotherapy. We might have to give some break. And with that, thank you all for, staying. Yeah, so it is, more is just, I think that came in. More is just more. So with this, thank you all my esteemed panelists, especially all international speakers and faculties who have taken the pain traveling to Delhi and, witnessing the last session, almost the last session of the day. Thank you. I think I have something on it. Thank you. Thank you all. Thank you so much.
So when do you go back?
Night.
Huh? Night. Good night. Both of you.
Well, go back.
I think this is
And officially chair.
Let's do that.
Photograph to the